Oh, there are so many yummy vegetarian options out there. You could try like lentil soup, veggie burgers, tofu stir fry. The possibilities are endless. All right, the new 2025-2026 lipid guidelines are out. And let me tell you, they are a big deal. We're talking about some of the most significant changes to how we manage patients in about a decade. So in this breakdown, we're going to get right into the most critical updates that will directly impact your day-to-day clinical practice. Okay, so first things first, let's talk about the major paradigm shifts. And I mean major. These are not just small adjustments, they are a complete rethinking of our whole approach to managing lipids. So when you look at these six big shifts together, you see a really interesting trend. The American and European guidelines are finally starting to converge. Think about it, bringing back hard LDL targets, mandating universal LP screening, it all points toward a much more aggressive and personalized way of treating patients. This is huge. It basically puts an end to that fire and forget statin strategy that we've been using since around 2013. Okay, so if we're going to be this aggressive with our goals, the big question is, how do we find the right patients? Well, it all starts with screening, and you'll see the protocols here have gotten a major overhaul. What you see here is a big push to catch risk much, much earlier, and then monitor it more consistently. We're now talking about a universal screen in childhood, believe it or not. Then, of course, the checks get more frequent as patients get older. And here's a really key takeaway for your practice. You've got to recheck that lipid panel 4 to 12 weeks after you start or change any therapy. That's a must. After that, you're looking at checks every 6 to 12 months. Now, this one is a huge practice change. Lipoprotein A, the ACC/AHA has bumped this up to a class 1 recommendation. That's their strongest possible endorsement. And get this, you only need to measure it once in a patient's entire lifetime because the levels are genetically set. That one number can completely re-stratify the cardiovascular risk for good. And the magic number to watch for, anything 125 nanomoles per liter or higher is now officially a major risk enhancer. All right, so you've screened your patient. What's next? Risk assessment. And this is where things get really interesting because the old way of doing things has been totally thrown out. We've got a brand new calculator and a much, much bigger role for imaging. And all of this is designed to get us to more precise, more individualized treatment goals. So say goodbye to the old pools cohort equations. The new standard is the AHA prevent calculator. And the difference is, well, it's night and day. First off, it was validated in 6.5 million adults, a massive, more modern group. It also, and this is so important, removes race as a variable, which is a huge step for equity. Plus, it adds eGFR to account for kidney function and gives you both a 10-year and a 30-year risk estimate. That 30-year number is going to be a game changer for talking to our younger patients about starting therapy early. And this brings us back to that treat to target idea. It's official. The risk categories from the new prevent score are now directly linked to hard and fast goals. And just look at the numbers. For our very high-risk patients, the ones with established ASCVD, the goal for LDL is now less than 55. That is an incredibly aggressive target, and it means we have to be on top of our game. Coronary artery calcium scoring also got a major promotion in these guidelines. It's not just a tiebreaker or a risk refining tool anymore. Now the CAC score itself actually drives specific LDL targets. For example, if you get a score of 1,000 or more, that's a class 1 reason to really intensify therapy and shoot for that LDL of less than 55. On the flip side, a score of 0, it gives you the confidence to safely hold off on starting a statin in certain patients. It's much more prescriptive now. So we have these really ambitious targets. The next logical question is, how in the world do we actually get our patients there? Well, the great thing is the guidelines give us a super clear step-by-step treatment algorithm. Think of it like a therapeutic ladder. And here's that pathway laid out. It's pretty logical. Step 1 is always going to be lifestyle and diet. Then we hit them with a high-intensity statin. If that's not enough, we add ezetimibe. But here's the newest piece of the puzzle, bempedoic acid. It's now slotted in as a key next step. It's a class 1 oral option, which is fantastic news for our statin-intolerant patients, and it's the go-to before you have to reach for the injectable PCSK9 inhibitors. And why did bempedoic acid get this promotion? It all comes down to the CLEAR Outcomes trial. This was a massive study. We're talking almost 14,000 statin-intolerant patients. And the result? A solid 13% reduction in major adverse cardiovascular events. That's the class 1 evidence that cemented its place in the new algorithm. Okay, let's switch gears a bit and focus on some key high-risk groups. These are populations that, let's be honest, are often undertreated, and the new guidelines have some very specific recommendations for them. There are a couple of real game changers on this list. First, for patients with HIV. Based on the REPRIEVE trial, the new rule is simple. If they're 40 or older, they get a moderate intensity statin, period. Doesn't matter what their LDL is, it's a universal recommendation. And then, circling back to statin intolerance, the guidelines now clearly state that bempedoic acid is the preferred oral choice. Why? Because it isn't activated in skeletal muscle, which is the root of the problem for so many of these patients. Okay, so we've covered a ton of ground. Let's boil it all down. What are the absolute key takeaways you can start using in your clinic, like tomorrow? I think it comes down to 4 critical practice changes. These 4 things really capture the essence of the new guidelines. Number 1, order an LPA on every single adult patient who hasn't had one. Just do it once. Number 2, ditch the old pooled cohort equations and switch over to the prevent calculator for all your primary prevention patients. Number 3, don't just prescribe a statin and walk away. Treat to those new explicit targets. If an ASCVD patient's LDL isn't under 55, you need to escalate therapy. And finally, number 4, start using bempedoic acid. For your statin-intolerant patients, it is now a go-to class 1 evidence-backed oral therapy. And that brings us to one final, really important question to think about. With this new universal screening, we are about to find out that roughly 1 in 5 of our adult patients has an elevated LPA. Think about that. So, knowing that you have a patient with this potent, unmodifiable genetic risk factor, how does that change how aggressively you're going to drive down their LDL-C to compensate for that risk? That's the new reality we're practicing in, even before we have drugs that specifically target LPA.